So today, this is what we were talking about, perioperative management on people who are on medications for opioid use disorder.
Mostly
buprenorphine, actually, literally buprenorphine. All right, so quick announcements. Of course, videos on are amazing. Let us know if there's multiple people in your room.
You get extra points if your video's on.
You don't. You still only get one free CME credit. Let us know if there's other people. I said that. If you have questions, send them through the chat. We'll watch that, address it as we go. Otherwise, by all means, interrupt us.
We could have a drawing for extra CME.
No, we can't.
Oh, okay.
Okay, so coming up in a couple of weeks, community collaboration. We're going to talk about some of the community important relationships when you're doing a successful program in a community. And we're going to talk a little bit about motivational interviewing, lapse, relapse, long-term management and surveillance. That is not what this is. We are going to talk about long-term care, transitional care units, what happens in those facilities when there's opioids and or opioid use disorder. And then our final session, you might get a survey monkey to see what you prefer to hear about. We have a couple fun ideas.
Yeah.
Tomorrow on the Wednesday, echo schizophrenia and substance use disorder. So that's super cool. And you get to meet our PA student who is not passing because he's moving to Washington State.
We're failing him.
And then you can see what's coming up. The ones that don't have official titles, you can see there in the end or the beginning of August. These will be fabulous talks. They have a million different thoughts. So we're just kind of wait until they've narrowed down their options.
You didn't mention my talk.
Well, yeah, they can read.
Okay.
And I was going to mention that coming up. So technical assistance, if anybody needs any help with anything, that's how you reach Kurt and I. Erin, our nurse, probably knows more about the clinical things than we do. So by all means, reach out. Don't hesitate, no matter what. And it doesn't have to be just opioids. The online resource site, this is going to have all the information that you can get onto any echo. You can get information, all the clinical forms, handouts, flyers. We are working through this. Yes. Slowly.
All right.
The weekly addiction, I'm starting
you're doing
today.
all the talk.
I am. The addiction connection today was the whoops, we lied. We had a bunch of different FDA approval for alcohol use disorder. And then we had a couple non-FDA approved treatments for alcohol use disorder. And then we, of course, found even more information. So there's even more information. So that is what Kurt's echo will be next week on the Wednesday echo. So the objectives today, we're going to kind of go through some of the buprenorphine science, different non-opioid options for pain management, especially different types of surgeries, and then how buprenorphine can be used as a pain medication itself. So these are more exciting, how the goals are. Things you need to think about if you have a patient on buprenorphine is how do you optimize that pain medication? So we don't really want to obviously stigmatize patients just because they have the disease of addiction. We want to treat them like everybody else, and they deserve to have the same pain management. I think this huge one is setting expectations for patients. It's having those conversations of this is what you can expect. And then how do you have continuity of care throughout? All right, key questions. These are kind of the things that we came up when we were discussing, like what's important for y'all to know. So I'm not really going to kind of go through these because you will learn it as we go. So we're going to give you a bottom line. Clinical Pearl, the answer to what do you do with buprenorphine patients who have surgery? And really, there's no official case-controlled, double-blind, placebo-controlled study on this. There is no answer. Things have changed over time. We'll kind of explain how that's changed over time, historically through now, and kind of the approach that all the experts and us non-experts all came to. Okay, so current research, the next slide is yours.
My God, this is the longest I've gone without talking. Okay.
I did that on purpose.
It's hard to just be the pretty face.
The next thing you know, I'm going to push your chair right out the door. Brittany, can you come down the hallway and grab his chair? Just kidding. Okay, so current research, like I just mentioned, is significantly lacking. It's a lot of retrospective studies, people looking back saying, what happened to these patients in the past? What did we learn from it? There's a lot of meta-analysis of a lot of case studies where they said, we looked at these 50 cases, and this is kind of the consensus the experts came from.
All right, so finally, we get somebody to talk some common sense here. So let's talk a little bit about the history.
In which case, I'll keep talking.
So,
the
so let's talk a little bit about buprenorphine. We just need to learn some things about it first. And I think that as we look at how we're going to take care of patients with surgical procedures, we have to understand how buprenorphine works and how it acts. And so one of the things with buprenorphine is really how strongly it attaches to the Mu receptor. So in a way, you want to think of this like buprenorphine is it's a magnet, and the Mu receptor is just a big hunk of steel. And how strong, yeah, that's pretty good, huh?
No, it's not.
And so how strong does that actually attach to that? And I think that's the important thing, because all of the different opioids are so different as how much attraction they have to those receptors. So traditionally, what was happening when we started doing buprenorphine years ago was that they would stop it before people would have surgery. And the theory, of course, was that they wanted to empty off those Mu receptors so you could get some Dilaudid or some fentanyl or something, and it would actually help their pain. And so when we came on board years ago, that was kind of the thought. Next slide, please. And in fact, there's been a lot of different articles that have gone on over the last, from 2009 to 2017.
This is the historical article.
The historical articles, and a lot of them talked about stopping it, and that that you could just stop and just go on with it. But then there's some of them started to pop up where the pain control was manageable when you would actually continue it. So nobody really had a great idea of what to do, but there was a lot of different articles in the literature about what people were trying, whether you would discontinue it or continue it.
Yeah, and the first time we had a talk like this from somebody else, gave this talk really early on in our echo world. The kind of joke about this slide was that all these studies, you can see there's multiple here, and they overlap in years, and they all kind of said there was like 3 different cohorts of what the answer was, so nobody could agree at all back then.
And everybody was doing it differently, and to a certain degree they still are. And really, what was the fear? The fear was that you couldn't control somebody's pain. That was the problem. If they're on that buprenorphine and it's basically blocking all those Mu receptors, how are you going to keep them comfortable afterwards, right? So let's talk a little bit about the science, because I'm the person that talks about science between the two of us. So I'll do the science talk, Heather. So
this is your one chance to redeem yourself.
Yeah.
Normally I do the neurobiology.
Yes. So just remember that buprenorphine is really a partial agonist. And again, we say that all the time, but really remember that it doesn't do the same thing as a full agonist as far as euphoria and pain control. Although we'll talk a little bit about how it compares for pain control with some of the other things like morphine. And again, the interesting part about buprenorphine is how highly it's attracted to that Mu receptor. Now,
that's your steel analogy.
Yes, steel and magnet. Remember that. But if you look down below, it talks about how strongly other Mu receptor agonists are attracted. And if you look at, for instance, hydromorphone, which is Dilaudid, that we all know is Dilaudid, that's probably one of the closest ones to buprenorphine. It's only 1.7 times less strongly attracted than buprenorphine.
That was a funny way of saying.
It's a funny way of saying.
Buprenorphine is 1.7 times more high affinity than hydromorphone.
Correct. Correct. And so if you look down the list, if you look at the bottom of the list, if you look at oxycodone, boy, buprenorphine can push that off the Mu receptor very easily, because oxycodone does not strongly attach to those Mu receptors. Now, often when we're talking a little bit later, and the way we have always told people to manage post-op pain, if you needed something, we frequently talk about fentanyl, which still, buprenorphine is 6 times stronger attraction to those Mu receptors. But remember, sometimes it's about how much is around. So again, and it's what's kind of led to that misperception that it's really tough to treat post-op pain if they're on buprenorphine, because buprenorphine will just push everything off. Remember as well that buprenorphine very slowly goes away. And so it will stay on those Mu receptors for 2-3 hours and won't let go. It's like a little crab in the water, Heather, just grabbing on and won't let go. And so it's really important that you understand that. She laughs.
You need to read like a book on like analogy.
Yeah, that's right. So remember that some of the other things we got to talk about, buprenorphine is actually metabolized by the liver. And as most of you may know, it does have an active metabolite, and that's norbuprenorphine. nor buprenorphine. And it's actually an active metabolite. So what that means is it does give some of the analgesic activity of straight buprenorphine, but it is not nearly as strong. Buprenorphine also does other things with some of the other parts of the opioid and the opioid receptors, like the kappa, which is thought to contribute to some of the reversal of that kind of that hyperalgesia.
So can I just explain?
Yeah. Mm-hmm.
So there's 3 different opioid receptors, the mu, the delta, and the kappa. And the mu receptor is what we always think about because that's the one where you get the euphoria. That's when we talk about as far as pain control and constipation and all the things. But opioids also antagonize. So they act almost like Narcan at the kappa receptor. And as we've had different talks in our Wednesday Echo, and you've done talks on this about hyperalgesia. So people who actually get the opposite, they get more pain on pain meds. So when you antagonize that receptor, which buprenorphine does better than the others, it actually can help minimize opioid hyperalgesia.
Yeah, which is interesting because if you look at opioid hyperalgesia, we talk about it frequently with things like fentanyl and fentanyl patches and stuff, but you don't hear much about it when we talk about buprenorphine and whether or not patients will get worse pain, because they tend not to. So that's a very good point. Remember that there's no studies that confirm, really the degree or the percent of these opioid receptor occupancy needed to give you pain relief, right? Or, how many of these receptors need to be covered to give you that pain relief or any type of reaction. So that's really difficult because there's just not the studies. These are things that people talk a lot about, is receptor availability. And just so you know, these things, the thing on the left and the thing on the right, are actually shown differently. And if you look on the left side, it talks about what percentage of the receptors are actually open at a particular dose. And so even if you look at a common dose, which is 16 milligrams, you still have 20% roughly of your receptors open. And the question then being, is that enough receptors if I give you a full agonist to give you good pain control? And even at 32, which we rarely use, you still have 10% of those open roughly at any given time. If you look at on the right side, it shows it actually differently. It shows how many of those receptors are covered. And again, 32, you've probably got 80 to 85% of those are covered.
I used this chart one because I couldn't get the other one. You had to pay for it, so I used this one instead. But
funds are short here.
Funds are short. There are no funds. No, I'm just kidding. And we always think about in our world that 8 milligrams is kind of that sweet spot for where patients are protected from an opioid overdose. That was kind of the thing we always in our background, like anything less than an 8 milligram dose, they're more at risk for having an overdose. Now with fentanyl,
in the heroin days, yeah.
I said before, I was still talking. With fentanyl now, we kind of think a higher dose, and you can kind of see why this was, because it's a fancy curve, not a straight line. So that's kind of why we thought that.
All right. So what does all this mean? Well,
I think this is me.
No, this is still me.
Okay.
So continuing buprenorphine. Well, that wasn't as, there's been studies, and I like to say this guy's name just because it's Komatsu.
It's actually a female.
It's a female. Okay, this woman's name, Komatsu. But she did a study and actually showed that if you gave buprenorphine, it really wasn't associated with any respiratory depression. It wasn't associated with any lower incidence of it was associated with lower incidence of respiratory complications, especially if you're giving it with a full agonist. And in fact, when we look at patients in different studies where their buprenorphine was held, they actually had a much higher risk of many issues, which we'll talk about in a moment. Patients that were continued on maintenance doses post-op have actually lower patient-controlled opioid analgesia requirements than those who were completely discontinued. Right?
This is like patients who got a PCA following a major surgery. If they were continued on their buprenorphine, they ended up not self-administering as much dosing through their own PCA.
And the second point to this is interesting because if you look at patients who discontinued buprenorphine maintenance treatment, here's the big problem. About 50% of these had that chance of OUD recurrence or death. And that's a pretty significant side effect of stopping your medication, in my opinion. And really, that's why we tell people that we just can't do it. In most cases, it should not be something you consider. And so when you look at the perioperative management of buprenorphine, kind of this conundrum, right? So what is the right answer for all of us? What should we be doing? There's a lot of case reviews. And in fact, most of, again, Heather said this at the beginning, most of what we look at with this is patient groupings where they have done different things, whether stopping it or starting it. And so you look, there's case reports, there's 2 case series. And basically, when somebody sat down and looked at all of these, they just basically made the recommendation that it's probably unnecessary and could be harmful to completely stop. And the second bullet point there, that evidence suggests that analgesic or moderate doses of buprenorphine combined with opioids, agonists have additive effects. So they actually get improved pain control. So I think that most of the people are still saying that it's just not safe to stop.
So this article in Pain Medication and Pain Medicine in 2018, this is the top title of the article. This is kind of the first article, case review, largest one that was done to kind of turn the tide on that previous thought, that you had talked about at the beginning, 2009 to 2017 articles. This was kind of the one that started the new thought process.
Yeah, and there's still people that will taper people down before surgeries. And so really continuing this whole thought, if you look at the research that was done on this particular paper, their conclusion really was it's almost always inappropriate to continue buprenorphine at preoperative dose.
No, almost always appropriate.
Yes, that's what I said.
No, you said inappropriate.
Oh, I'm sorry, appropriate to continue buprenorphine at the preoperative dose. And furthermore, it's rarely appropriate to reduce it. And so I can tell you 4 years ago, often we would bring people down to about 12 milligrams, which was kind of the theory at the time, to open up those Mu receptors. Now I never change my dose. I leave the dose the same. And again, one of the reasons we do is that buprenorphine probably produces similar clinical analgesic efficacy as things like morphine. And so although I think there's always been the theory, because it was a partial agonist, that we weren't getting as much pain control, I think there have been quite a few studies that have shown that in fact there is. This is actually a meta-analysis of all the case reviews and case reports. And this was actually published in 2020. And what they did is they looked at the 12 of 15 where buprenorphine was actually continued, and they showed that these patients had adequate pain control. There were actually 3 cases where the buprenorphine was discontinued. And what they found in those patients was that they actually needed more referrals for pain management. It was more difficult to titrate their medications. And in fact, a lot of these patients ended up getting nerve blocks to control their pain if they'd had their buprenorphine discontinued. The cases where they stopped it before surgery, which we almost never recommend.
Like several days before surgery.
3 to 5, which is enough time for, a fair amount of the buprenorphine to wash out. Pain control became very difficult. And these patients often needed much higher doses of pain meds. And again, that's very consistent with having built up tolerance to that buprenorphine. Go ahead.
So the biggest things is, where is it the highest risk? If you're going to consider discontinuing, which again is not the recommendation, but if people are going to, what is the worst patients to discontinue or taper down in? And it would be a patient where if you taper off, but you're going to start a pain med before surgery, that's ridiculously high risk of relapse and overdoses, as I think it kind of makes sense. If they've been in a program or have been on buprenorphine for fewer than 20 months, or they've had any type of unexpected urines within the last 20 months. So kind of that 2-year mark is the sweet spot for maybe not having as high risk. And then if they were discharged from the hospital or from surgery or whatever, and they never had that follow-up. They never had that transition of care, which is what we talk about all the time. Corrections and hospitals, like there's no communication between the hospital provider and the clinical buprenorphine provider.
And I think it's really important, especially if you have nurses, like things we're looking at now with follow-up with patients, is don't assume that the surgeon sent the patient out with the correct things or that the person has it. If they've had surgery, you should check in and make sure that their buprenorphine and everything is set the way it's supposed to be.
Right. And I think, I think hospitals have gotten better at setting up follow-up appointments prior to discharge, but they're never usually like right away. And I think that is, if you have a patient who just had surgery and you write on the discharge summary or discharge whatever, call for an appointment with your provider, it's better to have that clinical nurse, call that patient sooner to not only make sure the meds are good, like you said, which is hugely important, but to also make sure there's a follow-up appointment there. So we're going to kind of switch gears, and what do you do? And we'll come back to that and kind of give you the recommendations, but came across a little bit more research on this. And I'll explain the patient I had later and why this became such a huge thing in my mind. It's like, what do you do about a patient who's not currently on buprenorphine, who either has an untreated active opioid use disorder that they're just not currently treated, or they're at risk for one? They have a lot of risk factors that sending them home on pain medications is asking for trouble. Whoa, there we go. Okay, so the other patient, and it's important to realize, and I think we've said this before, is that when a patient are hospitalized, there's a lot of substance use that flows through the hospital. Like, just patients who are in the hospital have a lot of history of substance use. We think about tobacco a lot. It's on a lot of EMRs to like call in, or to order the patch when they first get admitted. But we don't really have good data on what percentage of patients who are having surgery actually have an opioid use disorder or have a risk of that. This isn't something that we really screen for. And so if you think about it, a person comes in and they had maybe used something and now they're going through withdrawal. It's kind of the whole thing we talked about with COVID. Like, is it really COVID and they're getting worse with COVID, or is it just that they're in the hospital with the severe illness? This is early on, and they're actually just withdrawing from their alcohol or withdrawing from their opioids. So it compounds their other health issues.
Let me just say one thing about that as well, is that when these patients present, and often this is like a motor vehicle accident or something like that, and there's concern about withdrawal, if there's a history of alcohol use, don't just assume it's just alcohol. And make sure, I think that one of the things when we're reviewing charts or we get a patient and there's not a urine drug screen that was done on top of, an assumption that it was a particular substance, you really need to know what's in there, because people can, now we see so much poly drug use that we really want to know what's in there and what we're treating.
Right. And, if it's a significant trauma, patients may not even be able to respond. They might have gotten pain meds even on the scene before they get to the hospital. Families might not know that they've been using other substances. So it's always important to just think this could be there. Patients who are at even higher risk are people who were discharged earlier, who have a lot of other medical conditions, patients who get readmitted, people who aren't, have good pain control at discharge, higher chance of overdose. So it's kind of that same cycle. There's a few articles out there about this where they basically state, yeah, it is safe to start MOUD during a hospitalization. This was really focused on patients who get admitted. They have an active untreated opioid use disorder. We talk about this in hospitals all the time. Hospitalists need to be aware of this and need to be comfortable starting medications for opioid use disorder. Whether there's a surgery or an admission for any other health event, they need to be comfortable starting that. There's an overdose and that's how they get admitted. They should be comfortable starting that medication. Patients who are started in the hospital, much better retention into treatment. And of course, especially if there's that good linkage. Even if a patient was started in the hospital and maybe they were discharged on a short course, they were released with an appropriate amount of medication. And even if they didn't follow up, they relapsed or lapsed right away, they still did better in the long term when they looked at a bunch of studies. Now, this was out of Brazil, but it's quite a few patients. And this is even starting, like a Belbuca or something, or Butrans, even before surgery, and just shortened that course. They used this almost a pre-op pain management, sent them home with a couple of patches. They didn't need as much other, full agonist opioids post-op. Post-op pain scores, if we're using the old adage of 1 to 10, they did just fine and they didn't have any more side effects. So even short periods of time do benefit the patients long term.
Just remember that although they did this study with transdermal, you cannot use that formulation if they have an addiction. So just keep that in mind.
We will get to that.
Yeah.
Yeah. There's a lot of gray zone as far as the addiction medications versus, the use disorder treatment medications and the buprenorphine for chronic pain medications. So there's a lot of gray zones there. So what about, this is that patient who doesn't have an active opioid use disorder, but maybe has a history of alcohol use disorder, maybe has a history of some other type of use disorder. Again, use begets use. A history of one use disorder increases your chance of another. So what do you do about their post-op pain? Do you just do your normal post-op pain management as you would for any patient, which is kind of historically and still not even historically still done pretty much everywhere? Or should you consider an alternative? This is a large study. This is legit one of the only studies on this. If you compare buprenorphine used as a pain management strategy after surgery to morphine, so in this acute pain episode, whether it's surgery or just a car accident or something, patients did not have any difference in pain, respiratory depression, or sedation. So, I think the respiratory depression kind of is a little bit different to me. You'd think that they'd have a little bit less, but I think the bottom line here is their pain was just as well controlled if they got buprenorphine versus morphine. Didn't really matter. Sublingual was just as effective. So there are IV buprenorphine formulations. Of course, there's the patches, but they said even the normal sublingual, the Belbuca, which is the pain medication film, or patients who have a use disorder, the plain buprenorphine, like the Subutex, just as good.
I'm just wondering if you could say that the person that did that study, Heather.
Kubalanza. That was also a female. Interestingly enough, I looked at this because you always say he when we're going through this. We've said this. And so I was watching it when I was citing, and I'll show you these same resources at the end. Most of them were women.
Perfect.
Anyway, so this was very interesting. And this is, and Drew, our student who's sitting next to me that's not on camera, and again, when I talked about this patient I saw yesterday, this study said the tablets in the IV were really good for post-op pain in high-risk individuals. So patients who did not already have a use disorder but were high risk. And they actually said transdermal, not suitable. You should not use the transdermal. So like a Butrans patch is what they're still referred to as, for that acute pain. Those are just for chronic pain. Now, there's a lot of other studies that disagree with this, especially at hospital discharge. And so there is not a consensus on what you should do. This is the whole shared decision-making and conversation with the patient and the surgeon. So what does this all mean? So if you look at ASAM, the American Society of Addiction Medicine, their guidelines for this exact thing, kids keep calling, from 2020, discontinuation of methadone or buprenorphine is not required. You just are going to need higher potency. So like your Dilaudid, your fentanyl, and you can still use those perioperatively. SAMHSA 2018 guideline, they were a little bit more ahead of the curve. They recommended that most patients continue through the perioperative period during the increased risk if it's discontinued. And I think that's kind of the approach we always took. It just seemed less risky. I always felt like, okay, let's just do the thing that's going to protect them from dying, and we'll just do what we have to do to survive the pain. So again, our approach just happens to be consistent with the expert consensus. So looking at the different pain classifications, different procedures, and this is kind of the breakdown that all the papers show, the mild, moderate to severe. So mild, your sprains, some tooth things. Dental issues, this is more infections, not major dental extractions. Basically, you treat with, whether it's nerve blocks, you numb the mouth, whatever, ibuprofen and Tylenol. There is no reason to change anything or do anything additional. Moderate, so fractures, mild, minor surgical procedures like a carpal tunnel release. Again, the nerve things, ibuprofen, Tylenol, or Toradol. So this is, your stronger ibuprofen in essence. So still no really anything. You continue the buprenorphine and add these on. Severe, so we're talking big surgeries. I didn't even put C-sections on here, joint replacements. This is when you're going to be like, let's give some IV meds or some oral stuff we'll talk about in a second, on top of their buprenorphine, on top of all this other stuff already mentioned. This is huge. Coordination with the surgeon. My kind of take on this is I will talk to a surgeon. I will put it in my, whether it's I'm doing the pre-op H&P, I will put it in there now. Actually, the Epic we have now actually has an entire section on, there's the drop down about what do you do about their anticoagulations. There's actually a drop down now. What do you do about their buprenorphine? If they're my Suboxone patient, I will write a special note to the surgeon, but I will just call the surgeon. Oh my God.
We're getting messages about our children. So.
Between about now, Carrie, is the answer. Sorry. Anyway, about my kid. Anyway, so I will call the surgeon and say, okay, what would you typically give to a person who's not on opioids at all? What would you typically send that patient home with after a surgery? Like, what would your normal discharge pain medication be? So, and then I weigh that, whether that means I increase the pain medications or I increase the buprenorphine. We'll get to that, but it's okay to have those conversations, because if you're not an orthopedic surgeon, you probably don't know off the top of your head what is a common, pain strategy here. Yeah. Put them in the instructions for the pre-op H&P with guidance, because that goes right to the hospital, that goes right to anesthesia. Everybody sees that, it's in one place. And anesthesia really should be aware of what's going on. Really should at least consider other non-opioid pain strategies. And then talk about the patient. Duh. Like, I think people sometimes forget to talk to patients. And having that conversation with the patient. Here's what would be an expectation in a patient for pain who is not on buprenorphine. Here's what buprenorphine itself can do for pain. Here's our plan, but ultimately we will have conversations throughout, because we don't want the patient to feel left out.
Yeah, and I think one of the things you have to be prepared when you talk to those surgeons. I had one that said I had already told the surgeon had already told the patient to stop their medication 5 days beforehand. And so be prepared to have that conversation why we don't do that, because of that increased risk, and try and reassure them that this is kind of the new standard. So right. I think that's very important.
And I think it's across the board with specialists. Buprenorphine is still one of those like newer things. It's not something that everybody knows about. Not everybody was trained about it. And so I think it's scary to people. You hear, oh my gosh, buprenorphine doesn't let them get high in opioids, so they must stop it, or I can't give them pain management. And I think most surgeons are very amenable to that conversation. And I will actually say at hospital discharge, I will take over. I will take over their pain management, and then they're very happy with that. Intra-operative period. And this is kind of where you kind of talk to anesthesia, don't tell them what to do, but just kind of say, hey, can we do things like, is there nerve blocks? Can you use other products? Can you do Expro, which is like a long acting, numbing medication? It's crazy. What else can you do? Avoid the benzos if possible. And we just kind of explain, the additive effect, but it's not a total contraindication, but it is important that, especially if you're adding a full agonist high dose opioid on top of a buprenorphine, you just want to watch their respiratory status. Fentanyl is kind of the preferred or Dilaudid, especially in the hospital. So what we will tell patients, continue the buprenorphine as prescribed, unless otherwise, we say something differently. Often this is what we do. We will split their dosing. If they're normally on twice a day buprenorphine, I will say, take those 2 films you take, cut them in half, and take it 4 times a day. So you're taking a half of your normal dose 4 times a day. The analgesic properties of buprenorphine are about 4 hours in length versus, the MOUD stuff is much longer. So you're just going to kind of take advantage of that. You're going to take it every, 4 times a day. You get the pain relief that buprenorphine as an opioid does offer. And then considering other medications that are, not, the opioids. Now, a patient with buprenorphine, and this is what Kurt alluded to many slides ago, might require higher doses of full agonists. Typically, we think about twice the dose. So if a normal patient was having surgery and they'd go home with, Percocet 5s, and they would take, one every 4 hours. The patient who's on buprenorphine might need Percocet 10s. How I recommend that being called in is still as the 5s and just take 1 to 2 when needed. We'll get to that. Understanding, yes, no, blah, blah, blah. Avoid using long acting. That's kind of the consensus with any type of opioids now anyway. Avoid benzos especially after discharge. And then again, those regional anesthesia techniques. Other things, consider the split dosing like we talked about. Sometimes increasing that total daily dose. I had a patient who had a major dental extraction, implants put in. He takes 16 milligrams total daily dose. So he takes 8 twice a day. For the week after his surgery, I actually called him in 8 3 times a day. I increased his buprenorphine, and then I told him to split that. So he took 4 milligrams up to 6 times a day of buprenorphine, or an 8 here, 4 there. And he never needed anything else. Tylenol a little bit. And then we just went back to his normal buprenorphine dose. So we really just, again, took advantage of that buprenorphine, and the patient didn't need any full agonist opioids, and he was comfortable with it. I was comfortable with it. Everybody went home great. Oral surgeon was a lot nervous until I said, let me handle his pain medication, pain management, and then they were happy. Give small quantities. If you're going to give, the Percocet 5s, give the 3 days to get your normal tissue healing. And I tell a patient, you might need more, and that's okay. I just want to know about it because, we want to make sure that your pain is controlled, and maybe there's other things we can do instead.
The only thing I would say as far as the 3 days, if that 3rd day is a Saturday, you might want to go 4. So it's just these common sense things to make sure that you get patients through a weekend so that you're actually available if there's an issue after. So again, common sense too.
This table, I'm clearly not going through it. It's from one of the journal articles that are cited at the end, but it kind of says the exact same thing, just in fancy journal speak. So
save that.
Leave that.
Yeah, we'll send that out someday.
Okay, so patient examples. I'm going to give the one patient example. I kind of just mentioned the tooth one, but the one from yesterday, and then we'll get it. Or we'll do that one last.
Okay.
I'll let you talk first.
Oh, okay. So we're just going to give a few examples of some patients that we've had in the last couple of years and how they were managed. And this is actually a 35-year-old guy that I saw that had a job where he hammered a lot and different things like that. And so he ended up with carpal tunnel. And he'd been in recovery for 3 years. So this is a guy who's relatively stable. So we worry a little bit less. Again, that 2 years being when we're worrying a little bit more about relapse. He had no other comorbid issues, and he's got scheduled for this carpal tunnel. And of course, I got a call from the orthopedic clinic about whether we should just stop his buprenorphine. And so really the question is, how do we approach his pain concerns? And he, of course, was, I don't want to take pain pills afterwards. How are we going to do this? So we looked at what we were going to do with him, and I actually talked with the orthopedic surgeon. I said, number one, we're not stopping his buprenorphine. We're going to just march that thing right through.
Should I not have caps locked that?
Yeah, don't stop it. And I said, number one, if you can inject this longer acting anesthetic, that'd be great. Why don't we think about a little Toradol? I know people have got a carpal tunnel that have never taken anything but ibuprofen. So this shouldn't be a big problem. Some people do get pain pills for this. And I think historically they'd go home with 40 perks, right? But we don't do that anymore. And so our post-op planning was all about ice and NSAIDs. And I did exactly what we just talked about. We had a total daily dose, and we just split it up into 4 doses instead of 2, just to give him the analgesic effect of the buprenorphine, which lasts just a few hours. And he did fabulous. And this guy, and I say fabulous, he did fabulous.
I should have caps locked that, right?
Yeah, fabulous should have been a cap lock. But he had tolerable pain. He had no lapse or relapse, and it went just perfectly. So, the carpal tunnel type surgeries, these things, don't be afraid to say, let's just break up your buprenorphine a little bit. Let's go with the ice and the ibuprofen. They should do fine.
I wanted to just say one thing.
Okay, just
and this
one.
is pretty universal. And for anyone who's ever taken care of patients, yeah, patients can go through this surgery without anything stronger, but everybody's different. And, some people might need something stronger, and that is okay. And it's making the patient feel comfortable to reach out if they are not doing well. You don't want them to not reach out. What if there is an infection or a complication? You don't, a lot of times these patients are more afraid of their pain that they're going to have, or they're afraid of being that stigmatized, because here I am saying I'm miserable. And so I'm not even going to reach out because people think I'm drug seeking or pill seeking. That's what they will say. And really they have some major infection. And so you want to make the patient comfortable reaching out for it.
I'm concerned that might have been more than one thing. Okay, let's move on to the next case. So this was my last case, and Heather has two apparently. So this is a 30-year-old female, and she'd actually been in recovery for quite some time, nearly 5 years. She's very healthy, very stable. Unfortunately, had just had a baby. And she was on buprenorphine 8. Not unfortunate that she had a baby. This was very complicated because she just had a baby. And so she was on buprenorphine. She was on 16 milligrams total daily dose, but she needed a scope and she needed pretty significant repair. And we were pretty sure that this was going to be an uncomfortable procedure based on the fact that her knee was locked up and they were going to have to do a number of things. So we did a little pre-op planning, talked to the surgeon. And again, what did we say, Heather? We said, don't stop the buprenorphine. And talked a little bit about other meds that we could give, but we were pretty much assuming that she was going to need a pain med for at least a few days at the minimum. And it frankly made her quite nervous. I think it always does when you have not used a full-on agonist for years. And so we made that plan that we would, again, the NSAIDs, we were going to use ice. We were going to use that total daily dose, and we were going to split it up just like we did with the person with the carpal tunnel. And so she got the repair. She had quite a bit of pain. I think Heather talked to her once or twice. I talked to her quite a bit. And so we made sure that she had the hydrocodone, and she was doling them out pretty carefully. She was using it 3 to 4 times a day for 3 days, but also taking it with ibuprofen. And she was trying to stick to just a 5 milligram hydrocodone, which again, from a standpoint of all the opioids, this is pretty mild. On that fourth post-op day, she still had quite a bit of pain, but it was better. And she was trying to find a way to not take the hydrocodone that day. And so what we did was we kind of shifted. I bumped up her Suboxone to 24 milligrams, much like Heather was talking about with the guy with the dental work. I just bumped her up to 24 for a week and then slowly back down. And again, she was taking that 6 times a day instead of 3. So she was taking 8-2s. She was taking half of that 6 times a day. And that managed her pain pretty well. She wasn't perfect, but with the ibuprofen, it was tolerable. And so I think that that worked very well. And I think, again, be flexible, understand that buprenorphine is good for the pain. You can switch to that completely and just turn it into a more frequent dosing. So a good example of kind of a moderately uncomfortable procedure.
Okay, so my first patient, literally my first patient that we ever came across that had buprenorphine, and it was one of those, oh shoot moments. So 24-year-old presented to clinic using mild withdrawal from heroin and meth, presented with her significant other who's significantly using substances, IV heroin and meth, and his mother who's also using IV heroin and meth. Coincidentally, 27 weeks pregnant, has not had any prenatal care, and now what? So this is going to digress a little bit from this whole question of perioperative. I promise we get back. But the first question for me was like, okay, what medication is best for this patient as far as her opioid use disorder? She realized she is pregnant and she needs to stop using drugs. So do we use methadone? We know that there's no precipitated withdrawal. We can just start the methadone, whatever. Good data in pregnancy. It's been around the longest. Downside, we'd have to get her to a methadone clinic. I had just travel issues, didn't have a license, already was difficult, lived legit in the middle of nowhere. And then, anticipating the neonatal opioid withdrawal, the baby's probably going to need medications for that in a NICU stay. So that was, one thought. Next thought, buprenorphine. And then the whole, is it Subutex or Suboxone, with or without naloxone? So the benefit is an X-waiver provider, which I happen to be.
That's lucky.
Or you find a clinical provider like that. We know that there's less neonatal withdrawal. There's no daily needs to transportation. So once we could get her stable or whatever, I didn't have to see her every day like a methadone clinic. The buprenorphine without the naloxone, so the Subutex product, is actually recommended in pregnancy the same level that methadone is now. But the buprenorphine with naloxone, the Suboxone, we also know is less likely to have diversion issues because of the naloxone. Downsides, she needed to be in some withdrawal to start. We can't just start her at any point. She would have precipitated. Without the naloxone, the Subutex, we know that there's a higher chance of diversion. Now, we know that methadone clinics have better retention, especially in early people in recovery. And so by saying you have transportation issues, it's better to not have to see you daily. We did have to run the risk of not, showing up or losing her. And there's just not as much data available in the Suboxone product to keep the naloxone in there. So what we did, she was already in mild withdrawal that day, which made my life even easier. Chose to start the Suboxone product. We talked with her about the difference. And again, she was living at that point in an environment where other people were using substances. So the diversion risk was very high. We did have that discussion. We did go over time up to the 3 times a day. And being pregnant often needs a little bit higher dose. Did see her weekly. The first week I saw her more frequently, but then I saw her weekly basically from her whole 3rd trimester. She showed up to all the visits. Urine drug screens were always as appropriate. Again, they were still using. She did move home with her parents to get out of that environment. So we were obviously planning. This is a first-time mom. We're planning a normal vaginal delivery where Tylenol ibuprofen would have been great. However, now she needs a C-section. This is now a major abdominal procedure. Talk to anesthesia and Aaron. Aaron's like, do Exparel, do tap blocks, do all these other things. And Exparel, I guess, wasn't there yet, but tap blocks. So she got tap blocks. IV Toradol was given in the OR, like before she left the operating room, and then 2 additional doses per the protocol. Continued her Suboxone as is, but I did give it to her, broke it down and gave it to her more frequently. The night of her C-section, of course, she's inpatient at this point. She took 1 dose of fentanyl, 100 micrograms, so a little bit higher dose, 1 dose of fentanyl. Oh, did I do this one? This is a double. Okay. She never needed anything stronger. She went home on post-op day 3, we discharged her. She stayed in the hospital with baby discharged on day 5. Baby never needed meds. Baby discharged with mom. Baby had a negative meconium scream. She literally got the 1 dose of fentanyl, did great on her buprenorphine, TID, as well as Tylenol ibuprofen. Did see her weekly up until that 6-week postpartum visit, just to make sure her pain was under control, make sure she was doing well. This is obviously a high social issue here. And then we gradually spaced her out. Okay. I want to talk about one more patient really quickly. I got time. So yesterday.
Why don't you stop this?
Well, how about I go through the summary first?
Okay, go to the
I'll do the summary first. Okay. Summary quickly, and then we'll take the screens down. It's not recommended to discontinue buprenorphine. It's not recommended in most cases to taper buprenorphine. I lost my mouse. Oh, switching to TID, split dosing lets you take advantage of the buprenorphine analgesic properties. Increasing the dose can also help minimize needs of other stronger opioids. Using other modalities. If you do need a full agonist, a full opioid agonist, you're going to probably need higher than normal doses. Can be used in first line and post-op pain in patients who have a significant risk. We'll get to all these questions. And ultimately, team-based approach and patient involvement is key. Communication. See, that gets to be caps lock.
I think one of the things too to remember is that never downplay the effect Suboxone may have on pain. I think early on in my career of using it, I would say to patients it wasn't as good for pain. But the reality is it probably is. And if the patient believes that as well, I think if they don't believe it, often they'll complain that it's not working. But studies show it's got pretty adequate pain control.
Right. So it's that setting expectations.
Yep.
And then that's how you reach us. And if you want to see all the darn sources, there's 3 pages of them. Okay, so I will get to the chat in 1 second, I promise. So this patient I saw yesterday, and this is what, of course, brought me to the point of even doing research on can you use buprenorphine for pain? This patient has been in recovery from alcohol use disorder for a good 5 years. Is the kind of patient with alcohol use disorder that cannot have a drop of alcohol because it will not go well, was not a pleasant human when they were drinking, and had a bilateral hip replacement 5 weeks ago. And I had talked with him prior, and very, I will not take an opioid at all. Well, we know that surgery is a little less painful. Anesthesia was aware, ortho was aware, did well with Tylenol and Celebrex, and, uncomfortable a few days, a lot of ice. Now this week is having a knee replacement. Well, knee replacements are a lot more uncomfortable. And so had this visit yesterday to talk about what are we gonna do about your pain management? Because again, very adamant, I will not take an opioid. I will just survive if I need to. And so the plan, after a discussion talking about this kind of gray zone data, is buprenorphine. So called him in some buprenorphine, and he's picking it up prior to surgery, going to do all the things. Anesthesia is aware. I talked to his orthopedic surgeon. They're going to do as many nerve blocks, Exparel, all the things they can do. But he's just going to take the buprenorphine as needed. So if it's a bad pain moment, or he's got right after PT or even right before PT, whatever, he's got one to take. And I just did the 2 milligram ones, just a minimal dose, can always increase it. So he'll have that 4 hours or so of pain relief. Again, we'll be in close contact to see how this is going. But setting that expectation is, yes, this is a kind of opioid, but definitely has much less risk than a full agonist would.
The questions. All right, a couple of questions popped up, and so we'll kind of look at those. It says, in my experience, so often pre-op was often not done by the primary provider, but by the most available provider. It means that the entire team that you moved it.
I have to, because it goes longer.
It means that the entire team that does pre-ops needs to be educated. Yeah, and that's really true, because a lot of the people that are doing these may not have a waiver, or even if they do, they may not understand the pre-op or post-op use of the Suboxone. So yeah,
that's a huge point. That's a huge point. And I think as a Suboxone provider, even if I'm not doing my own patients pre-op, I tell my patients as I get them, like, okay, if you would need surgery in the future, trust me, we can handle that. Please just keep me posted. You want to have that conversation. The patient finds out they need surgery, call that clinical nurse and say, hey, I'm having surgery. Because then if I'm not doing the pre-op, like my addiction clinic, I don't do pre-ops, I can send a message to that surgeon. I can send a message to the provider who's doing the pre-op, just to make sure everybody's on the same page. Yep. But that's a huge, huge point.
Danielle says, we have started to take over the post-op pain control, and I think we kind of prefer to do that as well. Due to full agonists need a PA, and that is complicated. And many of you probably run into that if they're on buprenorphine and then you write a script for Percocet, suddenly that gets denied. So these can be a little bit complicated. So yeah, be aware.
And that was the discussion Drew and I had with this patient yesterday. Was surgery's Thursday. Do I call it in now as Monday, or do I wait? And, we definitely called it in, and he's not on buprenorphine yet, but we called it in yesterday so we can get through that process. And I think kind of anticipating that ahead of time is huge. And I think that prior auth is going to go through easier. Danielle, maybe if you want to comment, if it's coming from the clinic provider who also does the Suboxone rather than some other random person. Okay, Isaac.
We've had better success with that, yeah, if it's coming from the Suboxone provider.
Which I think speaks to the respect of the Suboxone provider and team, and also to insurance companies trying to mitigate people getting on too many opioids too.
Wow.
I love this. So I'm going to point out who he is. Dr. Marsala, who wrote this comment, and I always say your name wrong. It's Isaac, just like my oldest. Does central pain stuff. So he's up on this way more than we are.
Way more.
I did have a little heart palpitation when you logged in, going, oh, great.
He says a number of studies showing 20 to 25% of people don't use any opioids after knee replacement, hysterectomy, and multiple other surgeries. So it's really important to tailor pain management to each person, correct? Yes.
And I think, I mean, you didn't put this patient in here. You had a tonsillectomy patient.
Yeah.
And I was an adult having my tonsils out, and I had to do ibuprofen and ice water because I got so sick on codeine, which is what I was given. But this was a high anxiety patient who's deathly afraid of pain, much more difficult to manage versus like this patient I saw yesterday, or the meniscus patient you had, very motivated to not use pain and to say like, hey, I'm here for you. We can do this.
Yeah.
It's knowing that patient.
Just understand that like tonsillectomy in an adult, one of the biggest issues we have is that there were two people prescribing. And so again, don't be afraid to take it over so that there's not confusion between what people are doing.
And believe it or not, as a primary care doc, you know, surgeons often, and anybody really, you kind of like, this is my job and this is what I know, and I do the surgery and I know the pain meds. And so it was always intimidating to me, like, I'm not going to call a surgeon and say, can you please don't do that? You know, like it's this fear of trying to stay in your lane. But I found that everybody in the surgical world that calls in pain meds is more than happy to let me take over the pain meds.
Yeah, and I think that when you call and offer to take over the pain control, they're like, yeah, please do.
Yes,
So
please
yeah.
do. I'm going to skip through that and I can just
Okay.
explain that faster. Thank you. As you will see in the chat, if there's any other questions, please just unmute and or, you know, type it in or whatever. But as you'll see in the chat, there's the survey for your credits for today. We are also kind of doing a little bit different of a survey thingy because we're trying to universalize how everybody, you know, I don't know, how the studies and the data and all those fancy things we need to do when you get state money, just to make sure that these are impactful and positive and motivating. So
All right.
all of y'all want to do what we do.
So if there are any more questions, throw them out there now, or we won't get.
Isaac, I'll just.
Yes,
Oh.
please.
Was somebody else talking?
Oh, go ahead.
So do a lot of post-op pain management for patients on Bup, and this is just such an important topic. I think a couple of things that have been helpful, especially if you can see them pre-op. So confidence in the surgeon is a really big thing for people. So I almost always make a comment of like, so-and-so surgeon is really great. You're going to be really well taken care of. Most of the time I can say that because I know the surgeons are going to, but something like that can be really helpful. And then people want to know that they're going to be taken care of. It's a really scary thing to go through surgery. So if you're going to say, hey, I'm going to be there to answer your questions or concerns about your meds post-op, that can be really hugely relieving for people. And then I almost always use the language of like, we need to be more aggressive in treating your pain because you have tolerance or things like that, because so often these patients are so scared no one's going to take their pain seriously when they're on Bup and stuff like that. So I really try to get across of like, hey, I get it. You have tolerance. And yes, we got to be more aggressive in treating your pain to try to help with that. And then just as Sarah said in the expectations too, even with all the things we're going to do to help you feel better, it's still probably going to hurt, and that's okay, but we're going to be there with you to go through it. So those are some of the things that I've been through with people. I had one surgeon want to wait 3 months to have a person off of a Butrans patch before they'd consider doing surgery. I had to talk to him about that. I had one lady who was abusing Percocet, and once she got on Suboxone, her multi-level fusion got canceled because her pain was way better because she wasn't going to withdrawal all the time. And so it's just, there's a lot of stuff out there that you can kind of help patients with by kind of getting into this. And then I'm not sure if you mentioned it, but at our hospital, we use a lot of ketamine, and we find that that's really pretty helpful for post-op people who have a high tolerance to stuff. So, you know, not everybody is familiar with that or has the setup at their hospital, but we've had a lot of good success with that. So I'll just throw those things out there.
Yeah, I think it's interesting too, Isaac. I think we're surprised, and I'm wondering if you are, how little there is in the literature about this particular management and how it's just based on case reports. I mean, there's not a lot.
Yeah, there's a lot of guidelines sort of as how we think we should do it. And we've sort of shifted, as you mentioned, from holding the Suboxone to now try not to touch it at all. And that's been a really big change. But yeah, both this and then even more so, we're running into, I don't think there's actually a study out there for procedural sedation. What do you do if someone's coming in for a colonoscopy on buprenorphine? I tried to look, I did a talk on this, mostly just asking for help on how to do this, because there's no studies out there about what you should do for that too. So yeah, it's still a kind of an emerging sort of area of figuring out, and we've been learning as we've been going through this over the last decade or so.
Well, now you're going to get an email from Katie asking you to present on the
Talk about
Wednesday
that one.
echo about procedural sedation. Thank you. The other thing I just wanted to end with is this echo will be repeated on a Wednesday echo probably in a couple of months. We're going to do it next week, but that was 2 back-to-back. So if there are other people in your organizations and or any of that, it will be coming back on a Wednesday at some point.
Yeah, someday.
So if anybody has any cases and you want to come on that echo and present a case, that'd be sweet too.
All right. Any other thoughts or questions before we go back to work? Hearing none.
But thank you everybody for your feedback and thoughts. This topic is fun.
All right. Thanks everybody. Have a good week.